Recording progress.
Good evening, everyone. And I wanted to start out with talking a little bit about the history of the development of these slides. Many of the lectures that I started before were intended to create a little bit of a foundation, genetically, historically, looking at primarily the genes and chromosomes as a foundation of leading into this discussion on gender dysphoria. As I started out these slides, I realized that the scope of this was quite large and that it entails a lot more than I thought it would. And especially if I wanted to break these up into 25-minute sections, I only cover a relatively narrow part of what gender dysphoria entails. And a lot of the things that we've learned about this have really been focused within the last 10 to 20 years. So, without too much further ado, I will dive into this discussion on gender dysphoria and start out with a introduction. So, starting out with this, the body and the mind are as inseparable as the relationship of the heart and the lungs. We have this concept that in medicine that psychiatry or medicine are these distinct and very separate entities. And as we've worked our way into medicine, we've developed the practices as such. When, for example, as myself as a hospitalist work with a patient who's admitted to the hospital for psychiatric concerns, if I'm going to discharge them to a psychiatric hospital, it's a discharge from medical care into psychiatric care. However, when we look at the relationship of the mind and the body, we see that there's this significant connection that you can't just separate the two. There's so much overlap and gray area. And I use a couple of examples here with like schizophrenia. We, over the years, have realized that schizophrenia actually has lots of associations with family and genetics. And same thing with autism. Our family, my family personally, has several individuals with autism, and you can see that throughout our family line. The other thing that I found that was very interesting is this idea that chronic pain leads to depression. And as you think about that for a second, for those with rheumatoid arthritis, where their joints are failing on them, they live with chronic pain and debility. And it would make sense that as the body suffers, the mind has to try to compensate or cope with these significant nerves firing all the time, or these pain receptors firing all the time. And that constant struggle to maintain balance and function is wearing over time. So it's not just the body that affects the mind, it's the mind that affects the body and vice versa. So as our minds develop, we can see that um, the relationship as the brain develops with the body can be altered, like with cerebral palsy, where the nerves don't actually fully connect where they're supposed to go. We look at traumatic events throughout life. Maybe it's abuse, or maybe it's significant events in war. Traumatic events that can lead to PTSD. Um, the On the same side of that, strokes and brain injury can lead to personality and behavior changes. And of course, that was going back to the individual who was mining stone, had the TNT go off, and the stick that he was pounding with went through a part of his brain, and his personality changed. So yes, strokes can affect people in different ways. So these relationships that we have with mind and body need to be recognized as very connected, though we treat them separately in medicine. So when I hear people talk about, oh, this is just a mental disorder, My next thought is, well, there's mental illnesses, there's mental disorders, there's mental symptoms, but a lot of them do have their basis in medicine, and so there's not this, black and white, but there's a lot of gray area in between. I like the last statement. So the relationship between mind and body is incredibly beautiful and complex. Um, we are just really even scratching the surface of our understanding of this. Yes, we can do all these neural mappings and MRIs and things like that. It's amazing to actually look at an individual and say, this is how it affects you. This is how autism affects you. This is how you interact with the world. And here's the things that we can help. And these are the things that you can help us understand more about yourself. In this next slide, I talk about the history of gender dysphoria. I approach this from different aspects. I looked specifically at the Diagnostic Manual 3. This is the psychiatry handbook that is they jokingly call it the psychiatric Bible. And the first real instance of what we would term as taking a diagnosis and setting up classifications and diagnostic criteria happened with DSM-3, which was released in 1980. Um, this this text created the concept of gender identity disorders, which was not included in previous editions. But the first thing they talked about was transsexualism, which they actually included in there that this was a heterogeneous disorder with a persistent sense of discomfort with one's anatomic sex. They listed several criteria that had to be present for at least a couple of years and not be associated with other mental conditions like schizophrenia. They also mentioned that they had to be not associated with other intersex or genetic abnormalities. And I'm going to dive into that a little bit further into this lecture, um, showing that this can be a little bit of a fallacy to think about that. Again, we're trying to separate these things, but in reality, there's this gray area and overlap that we need to take into account as well. This was also classified based off of a sexual orientation or sexual preference. And the challenge with that now is we realize that sexual orientation and gender identity and gender dysphoria are distinct in themselves. But again, there can be some overlap, which I think is what leads to a lot of confusion. A lot of the confusion has come from the fact that a lot of these terms have evolved over time. For example, sex and gender used to be relatively synonymous. We use them interchangeably. And you can see that in a lot of documents back 30, 40, 50 years ago, that they were interchangeable. As we evolved our understanding of identity and who we are as male and female, we realized that we needed a way to represent ourselves to the world. And so we started out with sex as the physical characteristics and gender identity as the mental characteristics. What was interesting with this setup of this chapter was the gender identity disorder was also located in the same chapter as paraphilias and transvestism. And a lot of people made this association that gender identity disorder was associated with these fetishisms, paraphilias, what often was termed deviances. And these associations created a problem in our culture, or created a situation in our culture that people with gender dysphoria were perceived negatively as a consequence of that. The terms, for example, transsexualism was replaced with gender identity disorder in 1987. As we evolved our understanding of these conditions, we changed gender identity disorder into gender dysphoria in 2013, primarily to avoid the negative association with the word disorder. That these conditions are a reality that exist in our society today, and that they've always been there. Um, so, as our understanding of gender dysphoria has grown over the decades, the definitions, classifications, and approach have evolved to better support individuals. So stepping away from the DSM, the diagnostic criteria that the psychiatrists use, I'm taking this now into a different pathway, working with the history of WPATH. WPATH stands for the World Association for Transgender Health, Professional Association for Transgender Health. And it started back in about 1948 with this Dr. Harry Benjamin, who was a German endocrinologist. A lot of people may recognize this name as kind of the primary figure that started this concept of treating with cross hormone therapy. And a lot of it actually had to do with this situation right here. He was approached by a mom with a teenager that basically adamantly felt that they were a female. They were born in the wrong body. They absolutely insisted that, and if this had persisted for many, 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 many years. And the mom looked at this child and supported them for who they felt that they were, and asked Dr. Harry Benjamin to develop a protocol of how we can best approach this. Dr. Benjamin created this system to treat them with hormone therapy. And what was really remarkable about this is that the treatment was very effective. And what this probably ended up into was a case review that, hey, this situation was evaluated. We considered all options, pros and cons of each situation. And as they started treatment, he realized that, oh, wow, this is actually very effective. So in 1979, a standard of care was developed using his name. He gave permission to actually use his name. And there was a diagnostic scale that was developed to identify people who were transgender or had gender dysphoria. At the time, of course, this was called gender identity disorder. Um, the problem with this protocol was there's a lot of flaws with it. Again, it came into what their sexual orientation was. The criteria was very stringent, and you had to meet. There were six different categories, and you had to be within the fifth or the sixth category to even be considered for hormone therapy. In 2011, the Harry Benjamin organization was reorganized into the World Professional Association of Transgender Health, and we are currently sitting at the standard of care version 8. What's interesting with WPATH is that when you look at this document, it's about 200 pages long. There are dozens of pages of research articles that are mentioned in it, and I've gone through most of these articles. They are massive amounts of research to support this. So, along those same lines, every major U.S. medical and mental health organization supports the WPATH guidelines. Everyone from the American Medical Association to the Endocrine Society to the World Health Organization. So there are thousands and thousands of people who have, in the medical profession and professional researchers, who have seen and support the WPATH guidelines. Taking the history another step further, I wanted to take this into ancient history. So we've looked at the DSM, we've looked at the WPATH guidelines and the evolution of recent history. Taking it back to ancient history also helps us understand a little bit more about ourselves as people in a society. In AD 8, Ovid was a Roman poet, and he told a story about Tiresias, who was transformed into a woman for 7 years before being turned back into a woman, or into a man, I'm sorry. So these gender themes were actually still even a part of ancient history. And a lot of this would make sense with even back then, because intersex people, people with differences of sexual development, existed even back then. And ancient societies did have their own midwives, people who provided for gynecologic care, delivery of babies, and they would see ambiguous genitalia, and they had to come up with these approaches of How do we interact with these individuals who have physical differences? So there's another story of Ovid uh, narrating a story of Caius, who was apparently a very beautiful woman and unfortunately was raped by Poseidon. In the midst of all this, Poseidon offered a wish, and Cyanus requested to become a man to prevent a repeat of the assault. I Unfortunate story. I that disturbs me so much in so many different ways um, that this individual was assaulted by somebody who is claimed to be a deity. Not that Kindness, requested to transition into a man, but that this event caused harm to Kindness. Um, and that very unfortunate that that happened. Again, this is clearly a story, but yeah. Moving on to the next category here. There was a Roman emperor named Elagabalus. I'm butchering that, I'm probably certain. In 200 AD is the first historical record of an individual asking to be addressed femininely and even sought surgical sex reassignment. This was in 200 AD. This is almost 2,000 years ago. You can actually see in records that are written by this individual that he requested not to be considered a lord, but wanted to be considered as a lady, and actually looked and sought out individuals who might perform surgery on them. So this is something that's been part of ancient history and even written down. There are several historical individuals who would be classified with gender dysphoria go through the centuries, but the terms have not been really identified. They talk about these experiences, these interactions, these symptoms, the wanting to be the opposite sex or gender. Um, and so the stories are really there. I think these ones were the most powerful ones of the bunch. Again, taking this back to the DSM and a lot of these criteria that were initially started. Early medicine conflated gender identity and sexual orientation or sexual preference. As our medical understanding has evolved regarding our sex and gender identity, it became clear there need to be an expansion and definite clarification of terms to better understand ourselves scientifically and medically. So again, we've evolved the definition of sex. We've looked at the definition of gender and taken it into gender identity. We've looked at gender expression. We've looked at sexual orientation. And all of these things, even though we're trying to clarify them separately, they overlap a lot. Gender identity does overlap with gender expression. They do overlap with sex. They do overlap with sexual orientation, but we also need to think of them distinctly. I posted this diagram in one of my previous videos when I was talking about sexes. When we look at sex and we look at male and female, we need to realize that it's a group of characteristics that makes us as a whole and an individual. That each one of these categories has been can and has been altered in certain circumstances genetically. In the center, we have gender identity, which is how we feel about ourselves, how we see ourselves internally. Gender expression is how we present ourselves to the world. And classically, we look at this as girls are pink and blue are boys. Boys are, they play with cars and Legos, and girls play with dolls. This is how we interact with the world. Sexual orientation, of course, is the gender or genders that one is attracted to. As I've mentioned before, there is overlap between these differences in sexual development and gender dysphoria. And you'll see that in another diagram that I post a little bit later. So there's a lot of theories, there's a lot of scientific data that supports this, how gender identity develops. It develops early in gestation and is developed in conjunction with sexual development. This happens about the 5th to 6th week of gestation, where the sex anatomical sex develops and the brain develops roughly in conjunction with each other. And early on in the question of history, they had this question about nature versus nurture. Is our sex defined by a set of genetic code, or is it an environmental uh, component to this? A lot of people will point back to 1967 with the story of Joan versus John, and his real name is David Reimer. And in 1967, David Reimer was changed from a boy to a girl after a botched circumcision. Dr. Money was the person who believed that nurture led to gender identity and recommended to David's mom that if you were to raise this child as a girl, they will develop and grow as a girl. So they did just that. They bought the girl clothes, toys, everything that they would expect with a gender expression for a girl. And they felt that as a consequence of those effects, that this child would develop into a girl. They even started giving hormones at the various times of development. And during this entire time, David Reimer was frustrated, experienced a lot of stress, anxiety, depression, and told his mom multiple times, I'm not a girl, I'm a boy. And later in life, after being told the truth, they transitioned back to a male. But because of all the events that led up to that, sadly, he eventually committed suicide. However, this experiment was during the time of David Reimer's growing up period was considered to be a success, even though it was flawed because they only perceived what they wanted to see. They didn't see things from David's perspective, which was really frustrating. So, unfortunately, the events around this led to dissemination of this culture of what gender identity is, and they focused on the nurture aspect of it. So in 2020, the Endocrine Society, which is a world organization, came along and basically said, in the medical consensus in the late 20th century was that transgender and gender incongruent individuals suffered a mental health disorder termed gender identity disorder. Gender identity was considered malleable and subject to external influences. Today, however, this attitude is no longer considered valid. Considerable scientific evidence has emerged demonstrating a durable biologic element underlying gender identity. Individuals may make choices due to other factors in their lives, but there do not seem to be external forces that genuinely cause individuals to change gender identity. And I think you'll kind of see that as you go through the rest of this discussion, that there seems to be this durable biologic component that this makeup of who we are really starts in gestation. Um, as is mentioned here, we make big choices due to other factors and influences, but you'll see that here in just a little bit. I also really liked this quote. Being transsexual, transgender, or gender nonconforming is a matter of diversity and not pathology. And I think as you go back to the discussion on sexes, you start to appreciate more and more that there is more of a spectrum of sexes, even though they're underlying two main categories, which would be male and female. What's interesting is when we look at our culture, and of course, I live in the United States, but as you spread out across the world, we've looked at the historical aspect of gender identity and individuals who have expressed uh, gender dysphoria. In various parts of the world, there are cultures that recognize that there are more than two genders. And here's a couple listings of them. And when I went looking at a map listing all these different categories, I found this map on pbs.org that did a really great job of listing all of these cultures with different genders. And they're all across the world. There's ones in Africa, Asia, Russia, Europe, the United States. They're all over the world. So it's not something just exclusive to what's happening here in the United States. This is worldwide. I had a very interesting time creating this slide and started out with trying to describe it as causes of gender dysphoria. And I had to look back and say, no, 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 this is actually more associations with gender dysphoria. Um, Causes are still being established. We're still looking to try to firm out how this works. However, having said that, there are a lot of connections to what can lead to gender dysphoria. These associations and causes are varied from person to person. And really, this is the important part about this. It should be approached individually. So the first one I've listed there is genetics. In terms of our sexual development, there are easily over 100 genes that are associated with gender identity and sex development. We have dozens and dozens of research articles to support this, that it's more than just XY. It's more than just um, uh, sex anatomy, that there's a lot more that goes into our gender identity as a whole and in our development than we see externally. There are some environmental associations, including some aspects of mental health, autism, schizophrenia, abuse, trauma, and in some cases, just straight puberty. As many will attest, that puberty is not a very pleasant experience, and we sometimes experience dysphoria as a consequence of that, as these physical changes do happen. Trying to understand and approach an individual individually is the important part about this. Weeding out or deciphering what led to the symptoms of gender dysphoria to develop is one of the important aspects of a collaborative effort, of a group, a multidisciplinary group of understanding how do we approach an individual with gender dysphoria and take care of them the best way that we know how. I thought this was very interesting. Historically, social learning and cognitive developmental research on gender development was conducted primarily with youth who were not gender diverse in identity or expression was carried out under the assumption that sex correlated with a specific gender. Therefore, little attention was given to gender identity development. In the past, we did not look at gender identity development. We looked at learning and cognitive development. We didn't see a lot of the youth that were a little bit divergent from that. And as a consequence, we didn't have a lot of research to support or identify what was going on before. We do now. For some individuals, gender identity development appears fixed and is often expressed from a young age. Again, going back to these associations, we look at the genetics part of about this, we realize, oh, yes, of course, it would make sense that if somebody has a significant genetic component, that these gender identity problems would exist relatively early on. It doesn't always have to be that way, though. There's a lot of variation of when gender dysphoria starts and when it potentially ends. Neuroimaging studies, genetic studies, and other hormone studies in intersex individuals demonstrate a biological contribution to the development of gender identity. I don't want to take away from the experiences of people with differences of sexual development, but there is definitely an overlap. There's an overarching gender identity and intersex individuals do overlap. Intersex individuals can experience gender dysphoria. Um, Intersex people can be transgender, and that's expressed with this diagram right here, that there is overlap, not always. As I mentioned in a previous presentation, with Klinefelter's individuals, there is a sizable increase of individuals with Klinefelters who experience gender dysphoria. And as a consequence of that, some of them become or are transgender. So how do we start approaching the treatment of these individuals? Gender dysphoria represents a massive array of individuality and requires a multidisciplinary approach. It's not just one cause, it's not just one association. And as a consequence of that, there is not just one treatment or approach that we have figured out yet. There's various treatments aspects of it, But this collaborating effort by many people is what's going to help us have success with taking care of treating the individual. And I like this as the care of the whole person. As an osteopathic physician, I was always taught to look at the whole individual and not just the individual parts. So I'm going to pause right there because, as you can see, there's a lot of information. This is going to be continued into a part two, potentially a part three, and multiple parts that may go forward. I'm not sure yet. Here are my resources. As you can see, I pulled from the DSM-3 and 5, and then the WPATH Standard of Care version 8. Thank you for your time. I am looking forward to some of the feedback.